Thank you very much. Assalamu alaikum and good afternoon. Thank you, Dr. Adil. I really commend you and congratulate you for such an elegant meeting that we wait for year after year, and bringing all these experts and mindsets together to show really how much we can do in our kingdom. And I would take this chance just to reply to some of the skeptics that have been raised all the time about the ability or the need for local guidelines. I think with the progress that we see in Saudi Arabia, the vision of 2030 that we are living in day after day, the magnitude of strength and empowerment that we're having, the expertise that we live in right now, and this is a testament for that, we are able to produce and develop our local guidelines. Guidelines are not inventions, by the way. It's gathering of the data and information, gathering of the experience, gathering of the reads of the experts into the research and data. And that's why we at the Saudi Heart Association and the National Heart Center thought of the importance and vitality of having national guidelines that can lead the practitioners to the local practice and the niches and glimpses of what we as practitioners see, probably different than what they see in UK or US or New Zealand or Australia, who all have their guidelines that direct them. Saying that, as Dr. Adil has mentioned, we at the Saudi Heart Association have developed several guidelines, acute coronary syndrome, chronic coronary syndrome guidelines, heart failure guidelines published previously in 2019, now being updated. TAVI guidelines is under development, and so on and so forth, helping people. And the reason, again, I say the importance of these guidelines, as you can see here, whenever we develop a new medication, the expected adaptation of the medication, I don't know if a mouse is working here, is within few years and probably maximum within 6 to 7 years. But the actual practice worldwide, not just in Saudi, it takes decades to adapt new practices and new medications. There's lots of inertia that delays, unfortunately, the adaptation of new medication, new techniques, new guidance. And that's why it's important not just to develop the guidelines, but again, to advertise it and market it in a very nice way. Now, this is a slide that I put in 2013. And I'm happy to say that we have, in heart failure, moved a long way. It's a very dynamic, one of the most dynamic, I believe, fields right now in development of heart failure. If you can see in the past, when you had a patient with reduced ejection fraction, all what you had was ACE or ARB and beta blockers. And by the way, the Europeans didn't even believe that the patient had to be on an ACE inhibitor in the start unless they were symptomatic. And then if you are still symptomatic, you might add diuretics, hydralazine nitrates, or aldosterone antagonists. And this is one of the evidence that it took a long time to pick up on the use of aldosterone antagonists as a target guideline, guideline-directed medical therapy. Now, 10 years later, it's part of the 4 pillars, major pillar that you have to use a RAS inhibitor with some difference between the European and the American guidelines. You have to use a beta blocker, mineralocorticoid antagonist, and SGLT2 inhibitor as a must in all patients with reduced ejection fraction unless it's contraindicated. And then you go for the others. Now, here, as you can see in the European, they removed the ARB, they put ACE or ARNI altogether. In the American guidelines, they recommend ARNI first, and if for a reason not allowed to use, you can use ACE or ARB. Again, they have the 4 pillars as a must in there. Now, as you can see, if you approach the patient as a stages of even pre-heart failure, we can probably call it pre-heart failure now, the same way as our endocrine colleagues call pre-diabetes, we should really approach our patients pre-heart failure. You can even start on patients on SGLT2 inhibitors, especially if they are diabetics, to reduce the onset of heart failure. When it comes to HFpEF, we always had a challenge managing HFpEF patients. We didn't even believe at some point that they are heart failure patients, and we looked for other causes. We didn't have much to do for years. For ages, we didn't have but diuretics and the management of comorbidities if the patient has atrial fibrillation or high blood pressure. Now, we are focusing more on HFpEF. We are accepting heart failure with preserved ejection fraction as a big issue, as a problem, and that needs to be tackled. And the guidelines right now tell us that as a class 2B, you all know 2B may be considered. You could consider ARBs or beta blockers, mineralocorticoid antagonists, or even RNA sacubitril valsartan, as you all remember from the Paragon trial. But the more good news is that we have now SGLT2 inhibitors that across the range of ejection fraction, whether you were in the reduced, preserved, or mildly reduced, mildly reduced mid-range, you have a reduction in cardiovascular death and hospitalization, and a reduction in all cardiovascular death. And that's across all range of ejection fraction. As you can see, SGLT2 inhibitors compared to the other 2B medications across the range of ejection fraction showed a significant reduction in heart failure hospitalization. So I'm not going to talk about the approach of using it. I just want to tell you that there's another newer medication as well for those who are still symptomatic on optimal medical therapy, which is vericiguat, and also included into the guidelines. Saying that, you all remember that the Saudi Heart Association has published in 2019 the guidelines of management of heart failure, and now we submitted the update, the Combined National Heart Center Saudi Heart Association focused update, excuse me, 2023. I do thank all the authors for all the contribution and dedication and hard work on updating such a guideline. We updated the algorithms, we updated the tables, we updated the way it looks and the management. I can't give you yet all the details because it's still under review for publication, but hopefully very soon it will be distributed. And I would also take the opportunity to thank everyone also for our recent publication from the Saudi Heart on the management of hypertension, just published last week. With this, I thank you all and congratulations again.